We've got clinical case, my beloveds. Let's go. What we have, a 25-year-old woman presents to the emergency department with sudden onset of a rapid, sudden onset of rapid regular palpitations and lightheadedness. She is awakened and alert. Her blood pressure 110/70 mercury, 11/7. ECG shows a regular EKG shows a regular narrow complex tachycardia, a rate of 180 beats, 180 beats per minute, with no visible P waves. No, okay. Assuming the patient is hemodynamically stable, what is the most appropriate initial therapeutic intervention? Good cardiological question, actually. What options we've got? Immediate synchronized cardioversion, administration of intravenous diltiazem, maybe verapamil. No, so not this one. Instructing the patient to perform a Valsalva maneuver. Administration of intravenous amiodarone. No, my beloveds, it's a classic presentation of stable paroxysmal supraventricular tachycardia. Most likely, Atrioventricular Nodal Reentrant tachycardia. So the question, that's the knowledge of the first-line treatment in the management algorithm, of course. So why option C, instructing the patient to perform a Valsalva maneuver, is correct answer. For a stable patient with regular narrow complex tachycardia, the first-line treatment is always to attempt vagal maneuvers. Maneuvers like the Valsalva, so bearing down as if having a bowel movement, or carotid sinus massage dramatically increase the parasympathetic vagal tone. So the vagus nerve acts as a powerful brake on the atrioventricular node. In atrioventricular nodal reentrant tachycardia that we've got, the arrhythmia is sustained by a tiny reentrant circuit with the AV node itself. So the increased vagal tone can temporarily block the circuit. Actually, why temporarily? For a long time. Breaking the tachycardia and restoring a normal sinus rate easily. It's a safe, non-invasive, cheapy, and often highly effective first step. Why the other options are incorrect? So what we've got, immediate synchronized cardioversion. This is incorrect. Synchronized cardioversion and electrical shock timed to the coherence complex. When they are large, it's a treatment of choice for a patient with, why not with paroxysmal supraventricular tachycardia who is unstable, that is hypotensive, altered mental status, or in acute heart failure. So since the patient is stable, this aggressive intervention is not appropriate initial step at all. What else? Administration of intravenous diltiazem. This is incorrect as the initial step. If it would be verapamil, okay, I do prefer verapamil in this case, but diltiazem, as all calcium channel blockers, that also slows conduction in very good manner. So I repeat, I do prefer verapamil through the AV node. It's a second or third line medication for stable patients, stable paroxysmal supraventricular tachycardia. The first line pharmacological agent is vagal maneuvers. If vagal maneuvers fail, it's adenosine. No, actually, I repeat, adenosine, it's great maybe, but anyway, I do prefer verapamil, but it's not the point. An administration of intravenous amiodarone, no, this is incorrect. Amiodarone is a broad spectrum, huge antiarrhythmic, typically reserved for wide complex tachycardia. Here we've got narrow QRS. For wide complex tachycardias or for refractory atrial fibrillation. It's not the first line agent for stable, narrowing, complex paroxysmal supraventricular tachycardia at all. So, my beloveds, high yield takeaway, high yield. The management algorithm for stable, I repeat, stable, regular, narrow complex tachycardia is a classic must-know for exams. First step, attempt vagal maneuvers. Second, if maneuvers fail, administer intravenous adenosine, let it be, or insert. If adenosine fails, or it's contraindicated, why not to use calcium channel blockers, or I don't know what, 4-class beta blockers like amio. But anyway, we understand, verapamil. So first, vagal maneuver. Second, if maneuvers fails, intravenous adenosine. And third, considered calcium channel blockers or 4 beta blockers. If not, there is no contraindication for amio. Stay blessed.